important clinical as well as an exam topic, Tympanoplasty and Ossiculoplasty. Over to you.
Outcomes, I think, was the
Yes,
brief I was given,
yeah.
wasn't it? Okay, it is important because there's a lot of smoke and mirrors when it comes to this subject. So let's have a look at this picture. You can see the tympanic membrane there. I think it's a right here. For those of you that are doing the exam, when you get something like that, put your brain into gear before you tell the examiner which ear it is. Just have a look at it, because if you get it wrong, it basically upsets that bit of the viva straight from the outset, and it's not a good start. And if you're not sure, don't tell them. If they don't ask you which ear it is, don't guess, just keep quiet. You can't give the wrong answer if you don't say anything. Okay, I think it's a right ear, okay? And you can see there is a sizable perforation of the pars tensor there. You can see the lateral process of malleus, and the promontory and so on. So the question I have is, who should we, why don't we ask Professor Ray. Peter, you've got this patient and they're going to have an operation, and the question is, what is the chance that you will close that perforation successfully with one operation?
I quote 85 to 90%.
85 or 90?
85 to 90.
Right. Okay. Based on?
Well, I quote two numbers. 85 because it's most commonly quoted in the literature, and 90% because it's my data.
Okay, so why do you bother with the literature then? Because you're even better than the literature.
Because it may not be me doing the operation. Maybe the registrar doing it.
Okay, all right. So 85 to 90%. It looks like a relatively straightforward ear. Perhaps that little bit of tympanosclerosis might be an issue with regards to closure of that. So an experienced senior otologist in the UK is quoting around 90%. 6 weeks, 6 months, 6 years,
Oh, no,
60 years follow-up?
No, and it's a really good question, because we tried to answer this question, and so I looked at 500 consecutive cases. And how easy is that? It's a nightmare, retrospectively. It's incredibly difficult.
Okay.
So, yeah, good question.
Follow-up is an issue. Okay, here's a lovely picture of a left ear, I think. So put your brain into gear before you commit to which ear it is. And just to orientate you, you can see the facial canal there. You can see an eroded long process of the incus with an ossicular discontinuity. We might as well stay with our esteemed professor from Leicester. So closure with some ossicular procedure of the air-bone gap to within 10 decibels in your hands?
I think that's a very difficult one to answer. It depends what technique you use on that one, but I'm much, much more pessimistic when I answer. I would probably quote them about a 65% risk, likelihood rather, of getting a decent air-bone gap.
Okay, all right. And we'll pick up on the importance of the factors that might determine that. One of the most important factors, it would seem, is the status of the superstructure of the stapes. Okay. If you look at this scanning electron microscope picture of the ossicular chain, looking from the vestibule outwards, what you can see there is probably the reason why it is so difficult to restore perfect hearing in middle ear and ossicular surgery, because it is an absolute amazing entity. And for all the atheists amongst you, if you want one piece of evidence that there is a God, just have a look at that, because there it is. There's your proof. Absolutely phenomenal.
What's his name?
I didn't say there was a name. I'm just saying. Okay. Superb. And therein lies the challenge, because emulating that through the surgery that we do is a great challenge. Here's another ear that has otosclerosis, and there will be varying quotes in the literature and from individuals around the outcomes relating to that, stapes surgery outcomes. This is a picture from a patient having surgery in the Cost Clinic in Béziers many years ago, who essentially had taken stapes surgery to its pinnacle. Do you quote their rates? Do you quote your own? Do you quote the literature? Who do you quote? Who do you believe? That's the other issue. So the problem, of course, is levels of evidence. And what I'm going to do in that respect is just talk about levels of evidence and the recent literature related to this and potential alternative strategies. The one you'll be most familiar with is the one that comes from the Centre for Evidence-Based Medicine in Oxford. And this is a kind of summary of it. So if someone says it's level 1 evidence, there are subsets. It's a randomized controlled trial, right down to expert opinion. And the problem in ENT, and including otology, is that the majority of the evidence is level 4 or level 5, occasionally level 3. It's very difficult to, for example, ossicular surgery, do a randomized prospective double-blinded controlled trial. I mean, some surgeons, when you watch them operate, look as though they're double-blinded, but in reality, you can't do that in surgery, and that's the problem with surgery. So a lot of the evidence is low level. It's not poor evidence, it's just low-level evidence. And if you look at what the UK National Health Service does for treatments and interventions, it grades it from A to D. And the NHS struggles because it often has to make decisions, as does NICE, based on a relatively low level of evidence, especially in surgical interventions. What about in the States? Again, they have a different grading system, but you can see the message is the same. You don't need to read all of this. And a lot of evidence is the opinions of respected authorities, eminent professors from Leicester, and it's level 3 evidence. But his audit of his own results and outcomes is potentially evidence that one might consider based on clinical experience or expert committees. And this is quite interesting because what they do in the States then is they look at the various levels of evidence and make recommendations as to what the clinicians may or may not need to do. And if you've got level C evidence, clinicians don't need to offer it unless there are individual considerations. So it has practical ramifications in terms of determining the level of evidence that's available to you. So if we look at the literature for ossiculoplasty from 2017 to 2018, I managed to find 16 papers, 15 of which are essentially level 4, level C NHS, level C in the States. So low levels of evidence. There was one randomized controlled trial comparing incus interposition with titanium prosthesis. So you can, I guess, do randomization in certain situations in ear surgery, but you can see it's relatively low level of evidence. So how can we improve that? Well, what about patient registries? I think some of you will be familiar with this, but basically I've summarized there what a registry is. And it has the great advantage because it's about a carefully designed and organized system for collecting data for various purposes, as I've described there. And the advantage is that you can look at real-world outcomes in the practice of medicine, whatever field you're working in, and therefore you can make real-world decisions about the effectiveness of therapies. And in a lot of what we do, this is the way forward, and the NHS is picking up, particularly NHS England, is picking up on the utility of registries because of the problems with low levels of evidence. And a well-designed, well-executed registry probably sits at about level 1.5. So it really beefs up the level of evidence that's available to you. Okay, well let's go back to the subject matter that we wanted to talk about. There's one take-home message from this picture about the prostheses that are available to you for ossicular surgery. And what is that?
Nothing works.
Well, everything works, or as Professor Narula said, nothing works. And that's the problem. There is not the perfect prosthesis. It goes back to that scanning electron microscope picture that I showed you in terms of what we're trying to emulate. And it's therefore arguable that whilst we've been trying to restore middle ear function from the 1950s and well into the 21st century, probably we've reached a zenith in that respect because of the restrictions of biology, not so much because of the restrictions of technology. And there are various materials. I won't dwell on this too long. There are relative advantages of these materials. Incus is there and doesn't cost anything. Hydroxyapatite is relatively easy to handle. Titanium, you need to put a bit of cartilage over it. It works well in a healthy ear in particular. I'm going to skip through this because whilst I would encourage you to use the Incus if it is available to you, I think, and I'd be interested, we perhaps picked it up on this in the panel, I think that the modern titanium prostheses probably have pushed the outcomes from ossicular reconstruction to another level. Not back to normality, but I think probably the majority of us are using titanium prostheses which are tailored to the biological situation in terms of size of the prosthesis in particular. But no one's going to criticize you for using the Incus if it's available to you. Hydroxyapatite, they're still available. I don't know whether people still use those. So this is the principle by the titanium, in terms of the titanium prostheses. The important thing is whether you're trying to put something on the foot plate or onto the head of the stapes, or often the neck, where you get a less secure fixation. You've got to put something between the prosthesis and the tympanic membrane, i.e. cartilage, in order to minimize the risk of extrusion. And it would seem that the data that's available to us, the chances of getting a hearing result that is good or very good in that situation is less than that situation. And you might think it's intrinsically because you've got something more secure there, but it might actually relate to the biology of those two ears being different that has led to more erosion of the stapes in the first place. It's just a clinical picture. You can see a combined approach tympanomastoidectomy. The prosthesis is in situ, and the cartilage is about to go in there in order to reconstruct the defect. And the other advantage is, whether they're the total ossicular replacement prosthesis or the partials, you can tailor the size to the situation you find yourself in surgery using these various sizes. I think you're all familiar with this. I find these very useful. One of the advantages of doing combined approach tympanomastoid surgery is that once you've put your prosthesis in, put the cartilage in, put everything back, you can't really see if you're getting a nice contact between the cartilage and the prosthesis. But if you've done your surgery this way, you should have a nice posterior tympanotomy where you can have a look and just check that everything looks to be satisfactory. Okay, so the other option when you have this situation, I guess that's a gap of about 1.5 millimeters, maybe even less, a couple of millimeters at the most, is to use a little bit of bone cement, as shown here schematically. We do this from time to time. Sometimes, in fact, I would say this is the technique that gets me some of my most outstanding audiometric results at 4 and 8 kilohertz. But also, exactly the same technique will get me an improvement in hearing that is practically zero. And I don't understand why. So you do exactly the same operation. One patient does fantastically, and another one doesn't. And it goes back again to the biology of the ear that you're dealing with. Well, we talked about closure rates. Peter Ray told us what his rates were. If we go back to a paper, it's now an old paper from Big Katecha and colleagues at Grayson Road. I think it was a college survey he did, if I remember rightly. You could see that in the Myringoplasty results were around 4 out of 5 closure of the perforation in 1,000 patients. And that must have been a national survey, I think, with about half of them having hearing improvement. So if you've got a patient with a hole in their eardrum or their tympanic membrane, and they ask you if their hearing is going to get better, you have to be careful that you don't over-counsel them in terms of being too optimistic about how much their hearing might improve. Here's another paper. It's an even older paper. You can see about 3/4. They're not as good as the surgeon's recollection data. When you think about your own results, you think, yeah, I must be at about 90%, maybe 95%. But when you actually go back and analyze your results, how long is the follow-up and what is the reality? And the hearing improvement is a paltry 8 dB, you can see in that series. And here's another one which showed that the improvement of the post-operative air bone gap was 12 dB in that particular series. So the outcomes of surgery for hearing, well, you can see that the most successful middle ear ossicular procedure for improving hearing is stapes surgery, but you're dealing with an ear that is biologically normal apart from the otosclerosis, and that's what sets that disease apart from those other diseases. post-op hearing improvement, ossiculoplasty 15 to 20 dB, Myringoplasty on the whole 10 dB. Do antibiotics make a difference in terms of outcomes? Probably not. Now, why is it important to know the outcomes of your surgery? Well, because the patients will ask you. And if you're auditing your results, you should be able to answer that question. That's the main reason, actually, why you want to audit your own results, but that's not really the reason. Probably to compare surgical methods, particularly if you're introducing new prostheses, new techniques that you might use. Comparing methods, we've said randomization would probably be the best, but conversely, I would say that historical comparisons are unlikely to be of any value because there are so many variables. So retrospective analysis is probably not worth doing. Collect your data prospectively. And ultimately, it's to assess patient benefits. So there are various data sets that can be used. This is an ear surgery minimum data form that I think Matthew Young and colleagues have devised over the years that looks at the hearing as well as the operative findings, as you can see there. And you've got to ask yourself, what is your aim when you're operating? What are the chances of achieving it? And will the success benefit the patient? And that throws up another question, of course, because you've got to compare the benefit in the operated ear with the opposite ear, the unoperated ear, because the overall hearing relates to both ears and not just one ear alone. And to that end, essentially, in 1985, I think it was, we had the Belfast rule of thumb from Gordon Smythe, which said that basically the operated ear needs to be brought to within 30 dB or better in terms of its average air conduction threshold, or within 15 decibels of the contralateral ear. So it's not enough just to improve the hearing in the ear that you're operating. You've got to take into account the unoperated ear. And that's what essentially was then put into a more scientific process, reported in this seminal paper, the Glasgow benefit plot, from our colleagues in Glasgow, which essentially describes how you've got to plot the 4-frequency average air conduction threshold of the operated ear as well as the non-operated ear, and then you can work out whether the patient has a chance of achieving benefit. So, for example, if you've got an ear, the ear that you're going to operate on and not operate on, both in group 1, you'd have to question yourself why you're actually doing the operation, if it's for hearing. If someone essentially has an operated ear that's in this area here, and the non-operated ear is normal in this area here, you're going to have to drop them down into group 1 before they will perceive benefit. And then if you extrapolate that to varying degrees of hearing impairment in the ear that you're going to operate upon and the unoperated ear, as the non-operated ear deteriorates, then the potential to improve overall benefit for the patient improves. And the key message here, I think, is that if you've got normal or near normal hearing in the opposite ear, you really are setting yourself up for a substantial challenge for the patient to perceive benefit unless they are in group 2 from the outset. And here are some examples here. You can see there's pre-op and the bone conduction, so you've got a bare bone gap. You've got to get that patient from there to there in order to perceive benefit. And here's another one that's got you could argue a mixed hearing loss, because I think the bone conduction thresholds are raised at the higher frequencies. And again, you don't jump 3 groups readily from ossicular or middle ear surgery. It just doesn't happen. And this was, I'll give you just a second to read that, because I think this essentially sums up the message that I'm trying to get across. It's an old message, there's nothing new under the sun. This was from Belfast. For the younger members of the audience, Gordon was one of the greatest otologists this country's ever produced, and sadly met his demise at a very early age, and who knows what he would have achieved if he had managed to carry on his work. But I think that's a really important message. What about other literature then? Well, does it matter whether you're You can tell this is an old paper because it talks about senior registrars and consultants. Whether you're a senior trainee or a consultant. I think this was for stapes surgery, and you can see that the air bone gap closure to within 20 dB, irrespective, that was all pulled together, was 88% and 76%. 3/4 of patients having stapes surgery in that series had an air bone closure of less than, an air bone gap postoperatively of less than 10 dB. 3/4, not 90%, not 95%, and a dead ear rate of 3%, which makes me think that must be 2, is that 2 dead ears out of the 183? Something like that. Okay. And the conclusion they reached was very reassuring for them. Our results are acceptable when compared with international figures. They may well have been in 1991. I don't think they are in 2019 now. This was the Royal College audit. Again, you can see 28 consultants and trainees looking at the same type of surgery, 2% dead ear rate there. And dead ear rates no worse than those of dedicated otologists going back from 1961 to 62 to 78. Okay? How far back in history do you need to look to be able to reassure yourself that you're getting good results? And the answer is, I'm not sure you should be doing that. Okay, I'll move on for the sake of time. Here's another example of a bilateral conductive hearing loss. You can see the right and left air conduction thresholds, the mass bone conduction threshold. You plot it on the Glasgow Plot, and the ear that you're operating on, you have to move it from there to there for the patient to perceive benefit. Whereas in this situation, where you've got a unilateral hearing loss, you can see that you start off there, and unless you get it there, they're not going to perceive the benefit. And that's the critical issue about ossicular surgery. So some of the things we do know is that I think that, and the literature I think would support this, although the evidence level is low, that the SAPI superstructure is a critical structure when it comes to ossicular reconstruction. And not necessarily because you can just clip things on more firmly, though I'm sure that's a factor. I think it may relate to the biology of that particular ear. It's perfectly reasonable, even in the modern era, to use the incus, as long as you're good at doing it. I think titanium has superseded all the other biosynthetic materials now in clinical practice. There's a lot of cartilage used for closing perforations and for ossicular surgery as well, in terms of keeping the prosthesis in place. Think carefully about why are you doing this operation, and will the patient benefit from it, and look at the opposite ear in order to try and answer that question. And the one thing I've learned in 25 years of practice is that I'll do exactly the same technically perfect operation in 2 patients and get 2 different hearing results, and I don't know why that happens. Maybe it's me, but I suspect my colleagues would probably say the same thing. Okay, I'll stop there. Thanks.